Hey, as you can probably tell from the thumbnails already, I recently had one of my lower incisors extracted for my braces treatment. I'll be honest, I feel quite insecure about having a visible missing tooth. There's a whole pile of research on how a visible gap in someone's smile gets read as less intelligence, less attractiveness, and less trustworthy. Pretty much all the negative social stereotypes get stacked all at one missing tooth. But instead of hiding it, I thought this would be the perfect time for me to start a series following my braces journey, episode by episode, from the seat of someone who actually going through it, explaining the terms and the decisions as they come up. Some of the terms you will hear in this episode, they are periodontitis, periodontal pocket, scaling and root planing, SRP, interproximal reduction, IPR, PAOO surgery, fenestration, dehiscence, and RAP. If those don't mean anything to you yet, don't worry, that's what this episode is for. Up until today, I have completed 8 dental visits. Visit 1 and 2 were consultations with different orthodontics. The first orthodontics I met wasn't a great fit for me. The conversation felt rushed and I left without much confidence. A few weeks later, I met another orthodontics in the same clinics. This time, the experience was a bit different. The doctor listened carefully, answered my questions, and took the time to understand what I wanted to achieve. That was the moment I decided to move forward. Same day, I also done the x-rays. But before braces, my orthodontist referred me to a periodontist because they suspect I might have a gum disease. Makes sense in hindsight. Moving teeth through a compromised bone or inflamed gums risks losing them entirely. So then the next 3 visits weren't with the orthodontist. They were with the periodontist. Turns out I had a moderate case of periodontitis, basically gum infection. They use a measuring instrument called periodontal probe to measure the depth of the space between my teeth and the gums. Any number below 3 mm is healthy. If it goes deeper than that, like 4 or 5 or sometimes 6 or 7 mm, then that means a periodontal pocket has formed underneath. Normal brushing and flossing can only reach up to 3 mm down. So once you got a periodontal pocket that's like 4 or 5 mm deep, 2 things happen. 1, you can't clean them at home anymore because you cannot reach them. And 2 is the bacteria will just keep collecting down there. Over time, your body triggers an inflammatory response to fight it off. And that causes the gum to pull away even more, which makes the pocket deeper, which then lets in more bacteria. You can see the vicious cycle. However, I did notice Waterpik claimed that their water flosser with a pickpocket tip can clean up to 6 mm at home. That's a claim from the water flosser brand themselves though, so do take that with a grain of salt. But I do think water flosser in general is a very effective tool, especially for someone like me with the braces on. So for my teeth, the treatment was scaling and root planing, the technical name for deep cleaning, where the doctors goes under the gum line and scale away all the tartars and the bacteria. 1 visit for the right side and the other visit for the left side. And that's wrap up my periodontal treatment. Now I'm bacteria free and tartar free and start healing. My 6th visit was my return to the orthodontics after 1 month of gum treatment. This time they took a picture of my face and my teeth and then did a digital impression of my teeth. I heard some older clinics, they are still using the old school alginate method where they pack a tray with a thick putty-like material and you bite it down and you hold it for several minutes while it sets. I mean, the feeling of the thing in your mouth is very easy to gag, right? So I'm just glad that the clinics I go to using digital impression now. Then after a few days, my 7th visit is finally about going over the treatment plan. My goal is to get all my teeth aligned and fix my flare teeth. The flare teeth just means that the teeth are kind of tilted outwards. From what I have researched back in the days, orthodontics had really limited options for crowded or flare teeth. Their default go-to was almost always pulling out 4 premolars just to create space and close the gaps. But honestly, we have so many better options nowadays. Doctors now can use open coil springs to gently push the teeth apart or do IPRs, interproximal reductions. Basically, that means to shave 2 sides of your teeth to create space for each tooth. Because of all these modern methods, getting 4 of your healthy teeth pulled should really be a last resort. Like only if the crowding is so severe that there's physically no other way around it. Unfortunately, I think there are still a lot of older trained doctors out there performing the orthodontics the way they learned back in college, which is pulling teeth on everybody. So if you found yourself with just a little bit of crowding, nothing too crazy, but your orthodontics immediately tells you that you need 4 teeth out, then definitely think twice before you commit. Now back back to the 7th visit where I go through my treatment plans. There are 3 options come up. Option 1, the most conservative option, IPR, interproximal reduction on some of my teeth. Basically, it means shave down some of the teeth to create the room. My teeth will end up straight, but because IPR can only create so much room, there might be some flares still remain. The option 2 was since my lower teeth was more crowded than my upper row, so the plan was to get one of my lower incisor extracted, which creates around 5mm of space, and that's exactly the room where it needs to strengthen and close the gap. And for my upper teeth, because I had already get 4 of my wisdom teeth extracted, so there's extra space in the back of my jaw, so the plan was to pull all my upper teeth backwards into it. So with this option, there's 2 trade-offs. One is I will lose the midline of my lower teeth, though my orthodontics tells me a lower midline shift isn't really noticeable to most people anyway. And second, because there wasn't much room on the back of my jaw, so the upper row can only pull back at around 2 to 3mm. It's a subtle change rather than a big one. Now looking at my teeth, you probably already know I chose the option 2, but sit tight. I almost went with option 3, which is by far the most aggressive path. Let me explain exactly what it is and why I eventually not to go with it. It doesn't mean it's a bad choice by any means. It just at this stage of my life, I decided not to focus too much on just the look, but maybe lean towards a more balanced and safer option, if that makes sense. So the option 3, the doctor were extracting 4 of my premolars and pulled the teeth all the way back to close the gap. The problem is with my alveolar bone or the jawbone. The bone around my front teeth is unusually thin. Pushing the teeth too aggressively through the bone that thin, and the roots can actually come out through the bone, as you can see here. Right, this is the gum. You can see the gum and the alveolar bone, and this is my front teeth. If I push the teeth too aggressively through the bone, you see the roots can actually come out, right? This is a condition called fenestration or dehiscence. To prevent that, my orthodontics recommends a surgery beforehand called periodontally accelerated osteogenic orthodontics, or PAOO in short. It's a mouthful of words, but it's also quite self-explanatory once you break it down. Periodontally refers to the tissue around your teeth. Accelerated means speed up. Osteogenic means the formation of a new bone. Orthodontics is just teeth alignment. So put together, PAOO means speed up your orthodontics treatments while helping you build new bone around your teeth. The way this PAOO surgery works is that the doctor will open up your gums. Yes, you heard that right. They will open up your gum and make a tiny cut in your jawbone. You can think of your jawbone just like any other bone in your body. It works the exact same way. When you fracture a bone, your body triggers a healing process where bone-destroying cells called osteoclast works much faster than a bone-building cells called osteoblast. Your body does this because it needs to clear away all the damaged tissue in the fracture area, which results in a temporary drop in bone density. So the bone is very soft at that time, which is perfect for fast teeth movements. There's actually a medical term for this called regional acceleratory phenomenon, RAP. So during a PAO surgery, the doctor intentionally mimic a bone fracture process by making those tiny cuts into your jawbone to trigger that RAP response, RAP response. And right after that, they place the bone grafts onto the wounded area. So while the teeth are moving fast through the softened bone, your body is also absorbing all the bone grafts. And by the time of recovery, your alveolar bone or the jawbone will end up much thicker than it originally was. So basically, PAO surgery borrows our own body's natural healing mechanism to make sure our teeth are moving faster and safer during the orthodontics treatment. Oh, the other advantage I found with the PAO surgery is that it enhanced post-orthodontic stability. One of the biggest fear we have as adults getting into the braces was relapse, right? The frustrating reality where if you forgot to wear a retainer for a few days, your teeth instantly trying to shift back where they used to be. Well, studies actually show that patients who get PAO treatments have much higher long-term stability because the surgery adds extra bone volume that hardens right after the teeth move into the place. It's like pouring concrete right around your teeth to permanently lock them into the place. If you don't know, now you know. But after hearing all these advantages, you might be wondering why I didn't go with option 3. Well, the plan presented to me at the time involved pulling out 4 of my premolars, and my teeth are not crowded enough to justify, extracting 4 healthy teeth just to align them. On top of that, my teeth actually aren't that flared out. The doctor told me another reason for the perceived mouth protrusion is that my midface is rather flat. Well, to put that simply, that's just a polite way of saying that my nose is rather flat. which creates an illusion that makes my mouth look like it sticks out more than it actually does. Plus, I just find this surgery is a bit too invasive for my liking, especially the part where they peel back your gum. Like what do you mean you're gonna open up my gum like that, right? At this point, it's not even about the science anymore. It's just how I personally felt about undergoing such a invasive treatment. So after weighing all the options, it brings us to the 8th visit, where I finally confirmed I will go ahead with option 2. And right then and there, they proceeded to extract one of my lower incisors and glue the bracket onto my lower teeth. And that's where we are right now. In the next visit, I'm assuming they will run the wire through my lower teeth and start closing the gap. And hopefully they will start working on my upper teeth as well. That's episode 1. Since this is just the beginning, the learning curve has been steep. New terms and decisions throw at me practically every visit. But every time I leave that clinics, I learn something new. So I figure turning that knowledge into a video serves 2 purposes. One is it might help someone else searching the exact same thing. They might get some reference from it, right? And 2 is that it gives me a record of my own teeth transformation as it happens. So if you got something out of this, a like and subscribe genuinely helps. Thank you for watching, and I'll see you in the next one. Peace.